Ευχαριστώ πάρα πολύ. Είναι μεγάλο τιμή μου που είμαι μαζί σας. Again, I'd like to thank the organizing committee for putting on a great session every year. This was a little difficult presenting this because I was following such great speakers and of course the audience that's here. And the title that Costa gave me really is a title that we should do all day. And that's what we're doing all day, is talking about complex situations. We know that variety and complexity in aortic stenosis patients determines the ultimate treatment strategy. And as Dr. Reardon pointed out, we need functioning heart teams to actually put all the information together to give the best chance of a good, successful procedure to a patient. And whether that means doing surgery, whether that means doing TAVI, or whether that means doing medical therapy, it's very important. Because ultimately, we shouldn't be just about putting in a TAVI valve, we should be about treating the patient appropriately. And again, you've seen this, everyone has seen this slide before in the European Heart Journal, but depending on the situation, we might favor one over the other, but ultimately we have to put it all together to see what is the most important. That's why, again, we need this heart team. And everyone is involved with this, especially the interventional cardiologist and the heart surgeon. But other people may come in and out of this team. You might need anesthesia during the procedure, but you might need their input before. You might need geriatricians, you might need neurologists. But you need a functioning way of treating these patients appropriately. I like to view complex scenarios in really carrying out the procedure. The access, the landing zone, and other factors. Of course, access can be complicated depending on the size of the vessel, tortuosity, calcium, and often we have to consider alternative access. In our center now, carotid has been the dominant alternative access. I still remember the days doing the transapicals, and they were fairly quick, but often these were sicker patients that other things would happen down the line. The landing zone is an issue. Again, this is where you need meticulous CT imaging, bicuspid valves, severe calcification, risk of coronary obstruction, and of course pre-existing prosthetic valves in there and how to treat these. I'm not going to go into details of every single one because again, that would take all day to do that and it would take people who know more about this than I do. But needless to say, we really need the imaging to assess these appropriately so we know the actual risk of doing the procedure in a patient. And nowadays with lower risk patients or younger patients, and again, lower risk and young is not always synonymous, but a lot of these patients have big vessels, they're straight shots. You know, technically, most of them are not that challenging. But when we do come against challenging situations, especially in younger patients, we have to ensure that is the right way to go in terms of doing TAVI or not. The other issues that we have to think about, electrical issues, complex heart conditions, again, concomitant other diseases, whether it's valvular disease, aortic aneurysms. We cannot disregard these things for the simple fact of putting in a valve quickly. And the non-cardiac risk factors, frailty and lifespan limiting disease. Again, we may decide on a 50-year-old to do a TAVI because we don't expect them to live till 60. That may not be the wrong thing to do. And of course, an 85-year-old who's going to die at 86, we shouldn't probably do anything with. This is Grube's somatic of the big five, and I like to add on top of that because, again, it fits with complexity in what we do. Stroke, again, it's always there. There are ways to potentially prevent it, but we're waiting for more data and meta-analysis for cerebral protection devices. But stroke is not just ischemic. Stroke can be shower, where patients maybe have delirium or other issues, cognitive issues afterwards, or an increase in any cognitive issues that they have. They could have mild dementia, now they've become moderate dementia. And of course, bleeding. And bleeding can happen during the procedure, but you also have to think down the line. If this patient is high risk of cerebral bleeding, and we're putting a valve-in-valve that may require anticoagulation, we have to think twice about doing that procedure in that patient. PVL, but I like to, again, add annular rupture, coronary obstruction, and other factors in that landing zone. Kidney issues, of course, and other metabolic issues. Post-procedure, thinking of heart block, but not just heart block, atrial fibrillation, and VT. And I like to look at atrial fibrillation because there's some patients that may benefit from surgical MACE on top of their a SAVR, and also left atrial appendage removal. And maybe surgery in this patient may be a better a better choice. And of course, bleeding, but not only bleeding, but vascular compromise and inability to anticoagulate. We have to think of all these. So for an example, again, I don't want to show, I tried on purpose not to show data. I wanted to show more concepts and discuss approaches. Frail 85-year-old, multiple medical issues, and you can see their BSA is very low. LVH, typical severe aortic stenosis, possible cardiac amyloidosis. We don't test for all these patients, but a lot of the elderly patients do have this. We're seeing more and more. And even on echo, we could see that this patient had calcium. Oh, sorry, this patient didn't have calcium. That's the next patient. An annulus that is easily treatable with TAVR, but small access. So we're taking a frail patient in their 80s, and we have very small access, and we have to decide, can we do this or not? And if we have other options, younger patient, we may say, let's do something else. This patient didn't have option in terms of surgery, and they didn't have option of alternative access. So we felt that we could go slowly, dilate up the vessels, and take care of this, knowing that there was a risk to doing so. I always like to imagine this as truck to tunnel size. We're putting a big device into relatively small vessels. And again, depending on the device you're utilizing, you want to ensure you can actually place the device through the conduit. So we went slowly and dilated. And it's not just about dilating, and this was going to be a balloon expandable, not just dilating to get the sheath in, but dilating to get the device through the sheath. And some people will go in and balloon inflate, but this was sort of a diffuse small vessel, mild disease. We thought dilatation would be the best. Place the valve in. Everything went pretty smoothly there. Got better. But then we're left with this. So exactly what we were worried about happened. Now, we don't know where the problem was exactly. Was the problem on the closure? It was a clean closure area, but a smaller vessel. Or was the problem further up? So went across, wired it, and actually treated this with coronary balloon because it wasn't a big vessel. So put in a 6mm coronary balloon over a coronary guide wire. And we could see that there was dissection as well as stenosis. There's the balloon. So we may have had two issues at the same time. So we had flow, and at that time I called our vascular surgeon. We have a very good working relationship. And I thought maybe we should treat this stent above the femoral head because I don't like putting in stents around the femoral head because of movement and crushing the stent. And you can see here the CT. He said, no, let's leave it alone. Let's see how it does. And as the surgeon said, sometimes the hand of God is better than hand of surgeon. And the surgeon was actually right. Was admitted to hospital, unchanged on CT, and patient did okay. Even with the stenosis that was still there, the patient was not that active to use their legs that much to have symptoms. So, oh, sorry, get back to here. So they did well with that, no problems, went home. So this was a win. Although it was initially a loss, it was a win. Tortuosity. You can see very tortuous vessels. Now getting through this is very problematic. And sometimes with extreme tortuosity, as an earlier talk today, we have to think of alternative access. There is simply too much tortuosity, especially when it's and concurrently with calcium, because you cannot straighten out these vessels. And I think in these patients, we have to try and straighten out these vessels as much as possible. So initially, I'd be a minimalist saying, let's just try it. But I don't do that anymore, having been burnt. So I'll use buddy wires, both sides, Lunderquist, whatever I need to straighten out the wire and be able to get the equipment up. I'll even put longer sheaths in the accessory vessel. Just so once the sheath is in, you're not worried about placing equipment through it, catheters, things like that. And it will help straighten out the vessel. So transfemorally, before, we don't want the procedure to end before it starts because that can happen. With extreme tortuosity, we should be using stiff wires to try and straighten out, buddy wires, long sheaths. Sometimes in these calcified small vessels, we have to use things like Rotaglide. And for our surgical colleagues, that's basically Caesar salad dressing. that we use for rotablator sometimes that is very slippery. Or we use propofol, which is a lipidic substance, and I don't know if any of you have tried that. Wipe a bit of propofol on a sheath or dilators and use those to go up, and that will help. Also not help put it in, but also help remove the sheath and the dilator. Sometimes we have to do balloon angioplasty of the peripheral vessels or even intravascular lithotripsy. And we have to be able to do other things, whether it's a cut down. Often we will use a cut down instead of perk these vessels because we feel we have better control. It's always easier to surgically manage these after a cut down than after a perk that's failed. And again, with TAVR access, you see more recently, we see that the dominant axis is femoral, and it should be because that's where the evidence is. And slowly, carotid, I think, has overtaken subclavian because of the issues. Transcaval is, I think, being done less and less now. I don't have any experience with transcaval. I have experience with all the other ones. But it can be finicky. And of course, apical, we have not done an apical in our center probably for 8 years or so. I don't know if other people, if they're doing much apical right now. That still may be an option, but again, this isn't something we do. And rock, you can see there's a cave. And there's another patient. There's a patient that has severe AS, 83 male, other medical issues. We see this vessel, this annulus here in the outflow tract. There is calcium, but we thought this was treatable. Surgery was not a good option for this patient. So we went ahead, we ballooned, nice and slow, put in a valve. Post-dilated because there was a paravalvular leak. Nice slow inflation, and it was a double tap sort of mechanism, not necessarily more, but just to make sure it was inflated. And very good result there. But unfortunately, a bit of a fistula. Being that this patient was not a good surgical candidate, we elected to watch this. As we're doing so, we were also looking at the ECGs, as we all do. A bit of a bundle branch, increased a bit, got a bit better. We said, okay, things are going well. Let's send them home on an extended Holter. They did well, feeling well. Unfortunately, surprisingly, VT. So, story continues. We brought the patient in. They were a bit dizzy. Arrhythmia was involved and felt that given this fistula, there is some evidence that patients who have a bit of VT can progress to more VT. And they felt the defibrillator was appropriate. So they did that. I didn't really push back on that because they know the area better than I do. And the patient was discharged. But the story continues to continue. Patient was shorter breath 2 weeks later. After a nice TAVI, sometimes we discontinue their diuretics. So this patient's diuretic was decreased, but with a little bit of the fistula, a little bit of overload, patient came back in, diuresed, did well, has no problem since. So we're medically managing this fistula. Again, heart team approach. The surgeon looked at the situation, thought this was a restrictive lesion. We should just leave it alone, and patient's doing very well. So again, the predictors of annular rupture, again, this wasn't a rupture per se, but LVOT calcium and balloon close dilatation, which we did. We have to be prepared for these things. So to prevent annular complication, prosthetic sizing and selection, choose the correct device if you feel there's a certain device that's better for this, procedural imaging. And it's not just doing the CT. A lot of centers will rely on a radiologist who really doesn't know what we do in the cath lab. I don't think that's good enough. I think we have to really review the images and understand the images. And all our fellows are taught level 3 CT when they come in, and they actually teach me. Modifying balloon inflation, nice and slow. It's like pulling on sutures quickly or pulling slowly on sutures. You don't want to disrupt a situation. And if there's significant calcification, sometimes you have to think of not doing the procedure. And again, other complications that can occur. That's why, again, meticulous planning, meticulous review. So what does the heart team need? Procedural excellence, procedural range, procedural humility, trust, and a view to the long game to ensure that our patients treated to the best possible way. And ultimately, the heart wants what the heart wants. And again, this may be in terms of love, but this is in terms of aortic valve, and the aortic valve is often needed. And when we cooperate, we can all climb Mount Olympus. Thank you.
Great. What a great, I would say, overview for this entire session. Let's. I have to say that the access issues are really the biggest one, because you get a problem there, and it's a problem with the stenosis. The worst are the perforations. We have been employing the ballooning through the sheath,
Yes.
As a safer way than ballooning before you pass the sheath. And with obviously particularly one of the sheaths, which is expandable inside the body, enters and can pass through a smaller arteries, and then you make it big before the valve. It's a little tricky, and I have to say, in the beginning of the maybe 10 years ago, we used to do some cases, not the small number, but not a big number, of common iliac access to bypass all of those. Never done that since we advent of the self-expanding sheath, the expandable sheath, I should say, and since the working with the vascular group for the endoconduit, so to speak, that you line up an endovascular stent graft, let's say, and then you balloon through it. Pretty much the same thing, and then you pass the sheath. I don't know what other. I'm interested. Interestingly, the carotid is indeed surpassed the subclavian, and is, to my a little bit of a surprise, is very much permissive regarding stroke risks. That's an interesting, I would say, clinical observation. Dr. Kilic has some comments, and then Dr. Damaskos.
Especially for the first case, you, for example, can put a contralateral safety guide wire before the insertion of the sheath. Maybe I am doing in every case, after proglide insertion, contralateral safety guide wire. In any problem, change the guide wire with a stiff guide wire and put a grave stent. So, because if any complication, vascular complication occurs at the index procedure, it is not very easy to come back from contralateral, and the patient is bleeding at that time. And you also mentioned the importance of the shockwave lithotripsy. It is really working. We did a lot of cases, especially in patients with circumferential calcification. We evaluated with the IVUS before also, and the shockwave really is working in femoral arteries, and it is a very good alternative.
I agree, and if it's discrete especially, I worry about people that want to treat the whole iliac when there's a nice simple carotid to go through. But absolutely, IVL is a great way to treat these.
Well, for those of us that are responsible for what the procedure cost and have our administrators, if I shockwave you, it costs me $2,000 extra. And so, unless I don't have alternative access, my young fellows all want to shockwave us. They find it so much fun. And yet I can get you your carotid in 3 minutes and it goes smoothly. I was just up at Cleveland Clinic 2 months ago. Samir Kapati asked me to come up there and do some carotids because their team were worried they're going to stroke everybody. Yeah. Now that they've just found out they're not going to stroke everybody, it's becoming their second alternative access. Shockwave works, but it's an extra $2,000. And again, my contribution margin is fairly slim, and I have to sit down with an administrator twice a year and justify my program.
So you have to imagine, that's in Houston, imagine in Canada. So yeah, we have to.
I thought things were free in Canada. Is that not true?
Yeah.
Yeah. It should be less money in Canada than the United States, or more money, I think so.
No.
There's more money in, more money out.
More
That's
money
why
out. Thank you.
More money in, more money out. Higher reimbursement, higher expenses. That's how it goes. Dr. Damaskos?
Sorry, was just thinking that cutting costs, perhaps we can use our vascular surgeons when we're trying to access the femoral artery. We actually do it a lot here in Greece. We consult with them, and sometimes they are the ones that put in the sheath on our behalf, and it is really working fine for this special category of patients. I just want to say congratulations on some excellent cases that were presented. And I think that we all have to be ready to fix problems, because all these fragile patients have different problems, and we have to keep improving our skills to be able to deal with them. So thank you.
Well, this is a nice.
About what James said.
Yes.
You talked about the CT scans. One thing that really bothers me in the U.S., a lot of sites just take their CT disc and send it off to a company, and then it comes back, and they never look at themselves. And would you send a coronary bypass to a surgeon that didn't look at the cath? Of course not. And instead of looking at it and deciding how best to do the procedure and which valve to choose, they just send it off and do whatever the company sends back. I think your comment about looking at the CT, in my place, if the fellow can't read the CT, doesn't get to do the case.
Yeah.
Yeah, interestingly, that's two interesting comments. To begin with, when we started up the TAVI in the United States, or generally, what was the #1 study that was heavily criticized by then pioneers of TAVI? Let me tell you, the CT. The #1 question was, why do I have to do a CT on everyone? Why do I have to do this? Why do I have to do that? For many people who are now advocating for CT, not Mike, but others, and it was very, very common. But we all learn together. That's the message. As I told you in the introductory comments, we now accept the structural imagers, part of the heart team, in SCAI, our interventional society. Why? They have become such integral part, and all of us have learned the CT and the intricacies of the CT and the importance of planning. And nothing like, okay, kind of looks okay in the echo, let's go and figure it out. You know, that might have been good for the 2002 to 2003 and 4 era, but now not in the 23, 24 era of this century. Absolutely. No, James, isn't that your experience there?
No, I agree. My first TAVI, I'll tell you straight, 2008 with John Webb over my shoulder, and we embolized the first one. And we sized it with TE. He thought it was okay. We thought there was only 2 valves available at the time, at least balloon expandable, 23 and 26. This patient clearly needed a 29, but we didn't know enough. So we were flying by the seat of our pants at that time. So CT imaging now is very important, and I think anyone who nowadays coming in, not grandfathered in something, but anyone who's being trained now has to know the skills to do that. Absolutely.
Yeah, indeed, that's my #1 lesson to the new fellows and all that, is that the fellowship is really with the imagers primarily, in order to make the decisions, because you're going to go out, they're going to join a program. Some of these programs rely to our new graduates to start them up or propel them much. So you're not going to have a senior person knowledgeable about those new things necessarily. Maybe they have all the patients that control all the referrals, but they don't have the experience, and they definitely don't need you to blow up the balloon or deploy the valve. That's the least thing they need. What they need is a planning, is the integration of these imaging aspects with the clinical techniques. So they really have to do the first few months immersed in the imaging laboratory, which is a bit strange because everybody comes in and they want to put a percloser and want to throw the valve in, but they have no idea what size they put. Well, that's not good. You know, that will really highlight that up top. And I'm sure Michael does the same for the surgeons who are even more impatient to implant and get out. Yeah. Isn't it?
No, I absolutely. We really, especially if you're going to take a healthy 65-year-old and not offer them surgery, which is low risk. A low-risk 65-year-old, this is a surgeon's dream. And in TAVI, if we're going to put a valve in, we have to make sure we get surgical-like results, right? We have to.
I tell you, it's all planning. It's all planning. Everybody wants to put the valve in. I could teach my wife in 3 days how to implant a sapien valve. Just hold still while I blow up the balloon. Yeah. But if the fellows at my place, if the fellows can't show me how to do a CT and which valve they're going to choose and tell me why they're choosing it, they don't get to implant the valve.
Well, a final comment, question I want to ask actually to both James and anyone here and Mike is the following. Interventional cardiologists, or cardiology if you want, pathway, they're very motivated to learn about structural techniques. They look forward to structural techniques. To my limited experience, the heart surgeons are really not so enthusiastic. And that's I would say, a sad realization from my point of view, because they've had about 20 years and even the new trainees, I think only a minority are truly interested in planning and performing the procedures. They're very much interested, I guess, to discuss in the heart team and have some, I would say, spotty presence in different parts of the whole process. But I don't see that much of a zeal as that what I see in the cardiology trainees. And, they're included, of course, but, where is that going to lead us in a few years? Are going to kind of, step up with a program, or they're going to sort of like sideline themselves due to their kind of not so much interest in, I don't know, or is the fact that we're repairing more valves, I want to make it more interesting to them. Clearly, doesn't seem to have made it that much interesting so far. And are we doing something wrong in the way we integrate this? And Mike, what is your what's the experience in Canada with the surgical partners?
Well, so there's a rule for my surgeons that you can only do transcatheter structural 1 day a week, and every other day you have to do open heart surgery. Whereas my structuralists, I want them doing it 5 days a week. It's always going to be different, and not everybody. I have 2 surgeons that do this with me. And not everybody does it. A lot of them want to come in and implant the valve, but they can't. Again, they can't implant the valve, so they can show me. They can sit down with my imagers and with my cardiologist, and basically do it. I can do this with my cardiologist doesn't show up as long as I don't bang a coronary. I'm good. In fact, it's not uncommon that I start with the fellows because they're up doing a STEMI, and we call up and say, send somebody down. We're getting ready to implant the valve. You got to be in the room, and then they go back and finish their STEMI. That's not the norm. And it's probably, you're right, George, I think it's become less the norm. I think this will eventually in the U.S. follow Europe, and it'll often become a single operator. But I hope that at least big centers where you're doing 300 plus a year maintain at least a couple surgeons that are deeply vested in this, because it makes a big difference if your surgeon's really there. You may not want to shockwave that bad iliac, just do a carotid, get the heck out of Dodge. Or if you're Jamie McCabe, you just do it percutaneously.
I agree with what you said. We're a fairly large center. This year we'll do about 500 TAVR, and we have 3 dedicated surgeons who have fellowship training in it that we've trained. We welcome this. A lot of our trainees, cardiac surgical trainees who come in want to do TAVI, but we've welcomed them. And we're one of the few centers in Canada that actually will train cardiac surgeons to do TAVR. So I may have a skewed view. In a lot of other centers, they don't want to train cardiac surgeons, so they may not feel welcome, and they may not go ahead and get that training because they won't see it as part of their realm.
We have 1 cardiac surgery fellow and 1 cardiology structural fellow every year. And everything we do is we invite our cardiology structural fellow to come scrub on our open cases and literally put them at the table and have them reach in there with a pair of forceps and look at the valve and feel the valve and get a feel for what the real anatomy is.
I fully agree with the heart team approach, but in real practice, we are seeing a lot of problems. For example, patient prosthesis mismatch is a very important issue. Generally, surgeons do not, and I'm not underlying different persons, but many surgeons do not look at CTs before the operation. And we are seeing a lot of, for example, smaller valves in large valsalva sinuses. Maybe aortic root dilatation surgery and the other parts of valve surgeries must be done in the structural heart surgeons, but for the TAVI, it must be done by the structural interventionalists. This is my opinion.
So in our valve clinic, not a TAVI clinic, valve clinic, attended by surgeons and interventionalists who do that, we do CTs on all of them now. So I think it makes the surgeons better surgeons to really know what they're going to put in, how they're going to approach the situation. That mimics Partner 3, where the gradients were pretty similar between TAVR and surgery for the first time, at least in the balloon expandable.
We CT everybody in the valve clinic, and we get an area-derived diameter of those that are going to surgery. My cardiologists expect me to send back a pericardial valve with an internal diameter that matches that area-derived. Otherwise, they're mad at me. TAVI has definitely made us better surgeons, no question.
Yeah, great. Well, this can go on forever for the discussion. I think we'll have to conclude now. Thanks, everybody, and we'll move straight back